Hi everyone, and welcome to HTS Labs Podcast, where we shine a light on the people and the ideas driving innovation in diagnostics and laboratory medicine. I'm Pat Clark, CEO of HTS Labs, and I'm delighted to be your host today. We're joined by a very special guest, Dr. Máire Lavelle, consultant histopathologist and lead breast histopathologist at the University Hospital Limerick. Máire is also a valued member of our governance board here at HTS Labs. With a wealth of experience in breast pathology, education and research, and a leading role in National Advisory Group, Máire brings a unique perspective on the present and future of histopathology in Ireland. Máire, it's great to have you with us, and thanks a million for joining us today. So today's discussion is going to be around the world of histopathology, particularly from a consultant histopathologist point of view. And so you're currently the lead breast histopathology consultant in University Hospital in Limerick. I'd be interested to kind of find out from you, kind of, before we even go down to the reason why you went to Limerick, but even before that, maybe give us a little bit of an insight into your journey, your path, or your pathway into medicine, why you chose that, and why specifically you chose histopathology, which is a kind of quite a niche, I suppose, area within medicine. So it'd be nice to kind of get a flavour from you just around that.
Well, thank you very much for having me. I suppose maybe if we just go back to basics and just before I go into, I suppose, how I got here is what I actually do. I just find generally when I'm out in public and I'm talking to normal people and I tell them I'm a pathologist, the first reaction is CSI and murder scenes, and that in forensic pathology is a subspecialty of histopathology, but that's not what I do. So what pathology is it's the study of disease, and I subspecialize in breast. So I basically diagnose breast disease. And how I do that is when a sample, so a biopsy, or if someone has surgery and they've had a lumpectomy or a mastectomy, I'm the person that tissue goes to, and I essentially put it under the microscope and I make a diagnosis. Okay. So how I ended up as a pathologist, that's a bit of I don't know how far back you want me to go. What got me interested in medicine in the first place. I have a very vivid memory, and I won't go through every single detail of my career, but my first interest in science and medicine was when I got Snoopy's book of biology as a child.
Yes, where many doctors were.
Where many doctors start. So I tried to look to see if I could actually get the book again. I couldn't find it. But it was, I started reading very young. I was about 3. And I think the book was actually intended for my brother, because my parents had very high hopes my brother would become a doctor, which, yeah, that was never going to happen. So it was Snoopy's book of biology, and it just started at cells, and they had everything pronounced phonetically. So it said, your body isn't made of bones, it's not made of skin, it's made of cells. And then it was very simple children's language, and I just found this fascinating. Like, what's the body made of? How does it work? Why do you get freckles? Because of melanin. They had all this. It was really, and I think that was my starting point of my interest in science. I was always interested in how the world worked. And as I progressed through school, I just always went for science. I did all the 3 sciences in school. I loved physics, loved chemistry, loved biology. I think when I suppose conscious this, as we're recording this, the CAO offers are coming out, and I kind of look back as like when I was 18 years old, and we're all 18 years old, I think I was far more idealistic. I mean, I wonder, would you choose to do in college now, later in life, as you would when you're 18? And at 18, I was like, I'm going to save the world. I'm going to cure all the diseases. I want to be a doctor. I want to do a job, all this meaning. And luckily I performed well academically in school, and I absolutely gung-ho to do medicine. If I didn't get it, I was going to just keep repeating my leaving cert till I got it. And then in medical school, as an undergrad, I went to Royal College of Surgeons in Ireland, in Stephen's Green. I think they have places everywhere now, but at the time it was in Stephen's Green. And I had Professor Mary Leader, she's a consultant pathologist, she's retired now, very inspirational. So as an undergrad, we got quite a good extensive, I suppose, teaching in pathology and histopathology. And I did get exposure to the lab. I did get exposure to slides. And I was always interested in it. And then when you finish college, you have to do a year of an intern. And as it happened, you have to interview then for what scheme you want to subspecialise in. And at the time, they were not all lined up. So surgery would happen in January, and internal medicine would happen in February, and pathology would happen in July. And so the only other area I was interested in was paediatrics, but the interviews for that were in February, and the interviews for histopathology were in, I think it was May. So I was offered a position in paediatrics, and I had 2 weeks to accept. And then I thought, well, what if I might end up with nothing. So I ended up taking the position in paediatrics. And my thinking was, well, I always want to do clinical medicine. And if I don't like it, you can always change. And I think that's something I always have, I suppose, throughout my life and everything, is that there's always a chance to change. There's always, I never feel like I'm always stuck in anything. I mean, it might not be fun to change your career, but it's a possibility.
Of course.
So I went into pediatrics for 2 years. And I suppose for me, I love kids, but that doesn't necessarily mean you love doing pediatrics. There's a difference between treating children and liking children. And it just wasn't for me. And I missed pathology. And I think a year into pediatrics, I knew I wasn't going to have a long-term career in this. And I have to say, I don't regret it in any way, because I think I needed to try the clinical side of things to make sure that it wasn't for me. I think if I went straight into pathology, I'd always have wondered, could I have done clinical work? And in college, the emphasis isn't on lab sciences, it's on clinical. So you're very much pushed and built into you're going to be a clinician of some sort, rather than a lab specialist. So I decided, no, it just wasn't my area. And I went back to histopathology, and
haven't looked back since.
I haven't looked back since. And it's funny that people in pediatrics met me 6 months after starting histopathology, and they're like, you're like a new person. I was just really happy. I think it's a type of specialty. I think you need a certain type of personality. I think we're very much viewed as the nerds of medicine, very detail oriented. And I suppose that the type of work suits me, where, I just kind of lock in and I'm looking at, very precise detail.
Yeah. On that point, actually, because histopathology, as distinct from maybe some of the other consultant posts or surgical posts, etc., you don't have a great deal of time. Now, correct me if I'm wrong on any of this, but you guys as consultant histopathologists wouldn't have a great deal of time spent with patient per se. It's more lab based, where you are honing in specifically on your slides and getting those diagnoses read and reported and back out to the clinicians within the hospital, but you're not per se sitting with the patient. Did you miss that part of where, when you were in the pediatric setting, you would have been, of course, out on the floor, meeting and greeting patients on a daily basis, to now be more lab based? Did you miss that?
Yes and no. I mean, I enjoyed interacting with patients, but I suppose that the type of work in the laboratory was more interesting to me, and it suited me better. But I suppose I don't miss it now. But that being said, I think histopathology, I think we're perceived as being in the lab and stuck away with all our slides, but actually pathologists were coming more and more out of the lab and interacting with patients. And being a pathologist, you actually need to be very good at communication, because you need to very clearly communicate results to your clinicians, to your radiologists, to your oncologists. You have, we call them multidisciplinary meetings, where you have a patient and their case is discussed in a room, and you have to have a minimum of radiologist, a surgeon, and a pathologist present. Usually oncologists, radiation oncologists also be present. And in my case, with breast cases, you also have all the breast nurses and anyone else who, feels it's relevant to be present and discuss that case. So you need to be good at communicating with people. But I think more and more, so in the US, pathologists are even training in ultrasound and actually taking their own samples. I think pathologists, and in the US, patients are now deciding to come into multidisciplinary meetings. So I think the future is that pathologists will probably interact more and more with patients. I think what might prevent that, particularly in Ireland, is just the volume of work. When you're working with the patient, you possibly could, by the time you speak to a patient and see a patient about their one case, you could have reported maybe 10 cases. Yeah. So there is, I suppose, getting the best value out of your pathologist issue there in terms of pressures, work pressures and time pressures.
For sure. And so then we touched on it a little earlier. So your speciality or your special interest is breast.
Yes.
That doesn't mean that you're not able to look at a lot of different tissue types, whether it be skin, etc. But your speciality is breast. Why breast? Why get into that area?
When I started histopathology, I actually thought I was going to be a forensic pathologist, as it happens. Right. And not because I wasn't aware of all the different areas, but I was always just and I still find it very interesting. And I'm trained in Ireland, and you're trained in general pathology. So if whatever you decide, even if you want to be a forensic pathologist in Ireland, you train in the general scheme. So you train in every subspecialty. So I can report in, across multiple subspecialties. That being said, the trend worldwide is that pathologists subspecialize again in certain areas, just because medicine's progressing so fast. There's constantly new guidelines, there's constantly new tests, there's constantly new, things are changing and reports need more. And if you're a general pathologist, you're still expected to report or make a diagnosis to the same standard as someone who is completely subspecialized in that area. And even in labs where everyone is, in theory, a general pathologist, the trend is that people have their special interests. So the person who's interested in gynae goes to all the gynae conferences and is the go-to person in that lab for a difficult gynae case. So for me, what happened was I was always interested in breast. And again, I worked with another consultant. She still works in St. Vincent's, Professor Cecily Quinn. And I suppose she got me quite early on as an SHO, and she reported breast screening cases. And she's just a very good teacher, and I really got my eye in to breast. And I suppose as well, another thing is that I think I was always leaning towards an interest in women's health. And obviously breast is predominantly women's health issue. After I qualified in Ireland, I went to the UK and I worked in Bart's Health NHS Trust, and that's the biggest trust in the UK. And I worked in a consolidated lab. So basically all the hospitals sent all their histopathology to one building, and is the largest laboratory in the UK. And it was so large that every pathologist was subspecialised. I was, I suppose, presented with an array of subspecialties I could do. And I have to say, I knew in my heart I was going to come back to Ireland at some stage. Yeah. And in Ireland, we are subspecialising, we're not quite there, just because we don't have the numbers for people to exclusively subspecialise for the most part. Although that being said, in the bigger labs, they're certainly subspecialising. The breast service, well, they were understaffed at the time. So I took breast, and I took some other areas as well. And I was just seeing huge volumes of breast pathology. And then due to illness, even though it was my first consultant post, I ended up being the lead for a short time. So that was a bit of a baptism of fire, but I learned a lot. And I learned a lot about reporting high volumes, working in kind of a high pressure situation. And I always just the area I was interested in. And when I came back to Ireland, I just wanted to keep in that space.
Well, I think on that, I mean, we're looking at, a number of years ago, of course, you qualified and you went and done your stint over in the UK, which a lot of Irish consultants tend to do. Came back to Ireland, worked here in a number of different posts. I think you're in Tala for a period of time, and obviously Limerick now. But over that time, and you touched on it a little bit there. There's changes are happening. What are some of those changes that you've seen in more recent years, particularly around, say, new technologies, and how they fit in with the pressures that we're seeing with laboratory medicine as it stands now? We know there's resource demands and issues, and we see that there's a lot more services provided now, and then that puts additional pressures on laboratories, etc. But maybe just take me through what are you seeing? What shifts are you seeing, and what new technologies are coming out that are helping you, your colleagues, and the scientific staff within the laboratories? Maybe you might just take us through that a little bit.
Well, there's a lot now. Some of these are older. I mean, I say that they didn't happen the last couple of years, but the changes since, I'm going to say, I started training to now. So I suppose in the broader sense, it would be digital dictation and voice recognition. Well, back in the day, you just dictate into a tape recorder, and a secretary would type out. So there's that. There's in the lab. I'm just going to start with the lab first. I'm thinking the specimen coming in. There's a lot more automation, and now everything is done, I suppose, is tracked in terms of specimens. We're given a barcode, and they're tracked now through the lab from being dissected and going through all the chemical processes before they come to a slide. And in the past, that would have been handwritten. And a lot of automation, where when you dissect a sample and you put it into a little cassette or a block, then a scientist would take that out by hand, and that's now being automated, and slides being stained and so on, instead of it being done by hand, is being automated. And there's a massive shortage of medical scientists. So, I mean, automation is welcome, because we just can't keep up with the demand, the work, and the people to supply it. And histopathology is different to some of the other laboratory specialties. So, so you get a blood test, a lot of that's put through a processor. So there's a lot of it's machine-based, but in histopathology, there's a lot of people needed.
It's very labour-intensive.
It's very labour-intensive compared to the other sciences. So there, I suppose, the bigger things the lab is automation. I suppose the big thing from the diagnostic point of view and change, and there is a strategy in Ireland for the next 5 years that histopathology will become digital. And what that means is, at the moment, I use a microscope and I look at a glass slide to make my diagnosis under the microscope. And instead of a microscope, I'm going to have screens, because that glass slide is going to be, imaged digitally and sent to a screen. And I'll be looking at big screens. And I'd liken it to radiology. Radiologists don't look at films anymore. They look at everything on screens now. And I think that, I would say that's comparable to what we're looking at in pathology. And it's a big development. I mean, obviously everything has its problems, and when you're trying to roll it out, it's difficult for someone who's used to working with, one instrument to then move to something completely different. But the advantages in terms of, I suppose, safely having patient data in a system, like slides can be broken, they can be lost, they can be mislaid.
Well, I'm thinking particularly when slides are moving around. I mean, you're talking about glassware.
Yes.
Very fragile pieces of glass moving around to different doctors, whether it be in your own hospital or whether it be sent out for a specialist referral.
Well, yeah.
So really this digital piece, it's kind of a game changer,
Completely.
isn't it? I mean, it's a huge shift from what's happened maybe the last, will I say 100 years?
I suppose probably I'm going to say immunohistochemistry would be a bigger game changer than the last 100 years, but yes, it's huge. It's big. And it is in common practice in the UK and in Europe. We haven't adopted for diagnosis yet in Ireland. I think most of the scanners in Ireland are being used for research, not for diagnosis. But the other thing that's great about digital pathology is that you can, I suppose people will call it AI, but I suppose the proper term is computational pathology, where you can use AI programs or you can use plugins or apps to do things such as counting certain cells, which, pathologists we do manually, but a computer can count things far more quickly. Certainly not at the point where machines are making diagnoses, nowhere near that. But I suppose as a complement
a
and an
companion
assist.
diagnostic nearly to what you're doing.
Exactly, an assistant in terms of, well, I think that it's staining this percentage of cells, and the program can go 28%, and I think 30. It's like having a little buddy help screening, but it's more, I'm going to say, measurements rather than a diagnosis. I'm certainly nowhere near putting it in and they're telling me it's cancer, although some of the programs claim that they're able to prioritize specimens, and I haven't used this, but where I think they analyze maybe the clinical details or do a quick screen, and then they present the case to the pathologist in the queue of things to report, saying this is more likely to be a cancer. Yeah. Look at this first. So it kind of can do a rough triage, would be another advantage of this technology.
And you mentioned there, and I've seen it, myself, or I've certainly spoken to plenty of consultants and scientific staff around the country on this, but the adoption has been slow in Ireland. Or is that even the right word? Maybe it's not slow, but it certainly hasn't been as quick to be adopted here as maybe the States or even the UK, which is our nearest and dearest across the pond from us. Why is that, do you think?
I think there's a few factors. I think number one is that the initial capital investment is very substantial. So if you're going to do it, you would want absolute buy-in from everyone who's using it. And I think, if an individual laboratory is going to do it, you have to putting that business case for, obviously hundreds of thousands of euro, and that's just your initial expense. Yes. The papers I have read, they say that, you will, it's worth its value, but it'd take about 6 to 10 years for it to, I suppose, show the value in terms of, turnaround times and so on. So there's that. I also think as well, people are just afraid of change, and it's such a precise speciality where, you're looking at individual cells, and, in cytology, you might be making a diagnosis on a group of 3 cells or 4 cells. And I think people are just, reluctant that, especially you spend 20 years maybe honing your skills on a microscope. I think there's a little bit of fear.
Yeah, of course.
I've had people bring up, I suppose I'm going to say, I think Ireland's probably quite a litigious country, really. And in medicine, you're looking at slides to a machine that can document exactly what you looked at, how long you looked at it, what part of the slide you looked at or didn't look at. And, we don't know what the implications of that is legally. If, a misdiagnosis was made, will that be used against you? I don't know. Yeah. The answer is that we don't know.
No one knows.
And we don't know the insurance implications for that. And we just don't know.
Well, for sure.
Yeah.
And I think what you touched on a little bit there as well, like a lot of this digital enhancement, for example, is predominantly now... it's predominantly used in a research capacity, and usually you would see that research work filter into more mainstream over a period of time. But you do have an interest, obviously, in the research and education side of what you do. For young pathologists coming along, what do you think the most important lesson is for those guys who are coming into this field?
Oh gosh, I'm probably going to sound very corny now, but I'd actually think the best advice I could give to, I'm going to say, anyone coming into medicine, let alone pathology. And I think it's something that as a group, doctors were very poor at recognizing this and helping trainees develop these skills, is, I would say, resilience. We're talking people who, I suppose, even get the points to do medicine and qualify and become doctors. You're talking about a group of people who perform very highly academically. They've probably never failed anything in their lives. They've probably never failed an exam. And then you're coming in, I suppose, to an area where, disease does not follow the rule books. You're coming to a system that might not be fantastic. You might be doing chaotic hours. You might not have the supports that you ideally would have. you're seeing, you might be doing rotation in A&E, you're seeing traumatic things. I mean, when I started histopathology in my first day, I did a postmortem. And there's no, I suppose, prep for that psychologically. I mean, I knew what I was going to do. It wouldn't have been the first time I'd seen a deceased person, but, it's still for most people that would be quite
it's an eye opener.
It's an eye opener, yes. And I have to say, when I worked in the NHS, they offered courses on resilience, and I remember the man running it say, "Oh, this sounds." I know people have probably kind of giving it a bit of side eye and going, "Resilience," rolling your eyes. You're all going to burn candles and incense, but actually, it's about, I suppose, just mentally fortifying yourself.
Of course.
And I the reason this really came to me was there's been a few instances, and it's taken me a while to actually pinpoint that it's resilience that is the important thing. So I went to an RCPI, that's the Royal College of Physicians of Ireland. They run master classes, and one of them, they invited a number of doctors, and again, I think they should have titled it resilience, but actually they titled it doctors who pursued alternative careers. And one of the people was Mike Ryan, so the director of WHO through the pandemic, and he gave his story of how he ended up in that role. That he didn't intend to work in epidemiology, he didn't intend to work at WHO. He was actually an orthopedic surgeon, and due to an injury he sustained, he couldn't pursue surgery anymore, and he was at a complete loss as to what to do. So it's kind of like that. I'm going to say what. Doctors a failure of some sort. He didn't know what to do, and then a place opened up, a non-paying research post in, I think, his public health, and look where he ended up. And they had multiple people come on, and they all had similar stories, and they all started with, "Well, it's just the way things worked out, and there's a series of coincidences." But actually, what it was every time they were met with the block, they're just inherently extremely resilient people, and they were able to make the best out of this, or to turn that situation. They never gave up. They never just down tools and went, "Look, if this is not working, I am going to go, I don't know what I'm going to do."
Yeah,
they all inevitably became successful because of their resilience.
It's a fair point. I think, particularly in today's world, we shield our children a lot, maybe a lot more than we would have in the past, and when these students, medical or not, but particularly medical, we're talking about that, and there's a huge responsibility on their shoulders, and we educate this cohort, and then we put them into a hospital scenario with patients or with responsibilities that they may not have faced up to this point, and so that resilience piece makes a lot of sense to me. That you can't teach that necessarily just directly out of a book, but maybe it needs somebody to handle that side of a medical student's life slightly differently, because it's something that I think makes a great deal of sense, that we should be instilling that sense into the students who are hitting hospitals day dot, without any real understanding that there's a lot of responsibility here, and it's very difficult, long hours, making very difficult decisions, maybe sometimes unsupported. So that makes a lot of sense.
Yeah, and they don't focus on, I'm going to say, the negatives in college. And I suppose it is kind of funny. You do exams, and you might do an exam, and you might be given an ethical scenario, and you give the right answers, but that might not be how it pans out in real life.
It's always the way.
And I remember one trainer of mine, and again, said to me, it's probably the most backhanded compliment you could ever hear. Because I've never witnessed anyone fail like you, Máire. You're the best person at failing. Whenever something goes wrong,
Thank you,
you turn it around. And she goes, "We need to get you to give a talk to all our trainees on how to fail well. And we have to come up with the name." And I was saying to her, resilience. You're talking about resilience and not failing well. But, as I said, just to take your point on these people, it's specifically these group of people, high achieving, type A, perfectionist people. And we're the type of people who don't handle failure because we possibly never had that.
Yeah,
or especially when you're, 18, 20, and you've sailed through all your exams.
Oh, for sure.
So yeah, I think that's it's a little something that I think we could do better with, and I think we need to do more with that with our medical students and our trainees.
Yeah, for sure. I would agree with you. And then just in terms of, obviously there's a training piece, etc. And a lot of training, of course, comes from that research perspective. What are you working on at the moment yourself, or what are you looking to achieve over the next number of years from a research perspective, outside of your own day-to-day diagnosing people with illness?
Okay. Well, a lot. So I, first of all, have just got ethical and legal approvals through for a tissue biobank for breast cancer in UHL. And what that means is, obviously with consent, that patients can donate their tissue, and we'll create a bank of tissue for the purposes of cancer research.
Brilliant.
Now, this isn't a new thing. This is, happening in many other hospitals and across subspecialties. And there are other biobanks already in Limerick, but they haven't had a breast one. So I'm very pleased about that, because really, with all research, I think you need access to tissue. Really, just that you need access to the cells, you need access to tissue, and you need a pathologist to help and support and develop that. So we just got that through, and I've teamed up with the School of Medicine, but also engineering in UL University of Limerick, to look at AI in breast pathology. And to facilitate that, I was very fortunate to be awarded a grant from the HSE Spark Fund, and that's a fund for innovation to support innovative projects. And they're funding a digital scanner for myself.
Hey.
Not for me personally, but for UHL, which is fantastic.
Brilliant.
Because we can now not only form a tissue biobank, but we can form a digital biobank.
Brilliant.
And we can train, hopefully, AI on and look at what we can do there. I can't reveal all the secrets on what we're working on at the moment because it's still in progress, but we're doing a lot of projects with AI and what AI can do, and testing the limits of AI using breast cancer specifically. But that being said, I'm hoping as well to use this scanner for diagnosis. So that might mean I might be one of the first pathologists in Ireland diagnosing digitally, which would be great. And there is a lot of interest there. This is a HSE program that the people who will be rolling out the digital strategy for histopathology, I suppose, are looking with interest at how I get on.
Yeah.
And in addition to that, I suppose I'm just looking to see the improvements in terms of, as you were talking about transport of slides, if patient transfers their care from Limerick to Galway, physically those delicate glass slides have to make their way to Galway instead of pressing a button. And things like computational pathology, I'm interested to see that as an aid. And for some tests, I have a scientist screen, and that could replace a scientist. So I'm freeing up a body to do other more important work that can't be automated. And there are multiple purposes. But that being said, it's not just breast. And since I suppose it's come out in the hospital that I got this machine, there's some fantastic people working in research in Limerick. So I've been approached across multiple subspecialties going, can we please use... In fact, we basically are getting, will the machine cope with the amount of projects that want to go through it? But it's great. It's
that's
really,
brilliant. No, that's excellent, and congratulations on that, because that's no small feat that you've managed to achieve there. And one of the things you actually mentioned there were scientists and freeing up scientist time. I just want to move to that a little bit if we can. So I want to try and incorporate the relationship between your scientific staff, so the guys that are doing all of the hard yards in terms of cutting up your sample and getting it stained and onto slides and doing all the work that those guys do. And then it's a unique discipline, histopathology, in the sense that the histopathologist and your scientific team work very, very closely together, because it's a kind of a dual approach to really it's all of the technical work at the front end that the scientific staff are doing, and then onto you guys for the diagnosis. How important is that relationship with your scientific staff in your laboratory?
Hugely important. And again, we're sort of going back to communication, where I think there's maybe a public perception about pathologists. We lock away ourselves because we hate patients and we hate people and we don't want to deal with anybody and we just want to deal with dead bodies and we lock ourselves away in an office. And in reality, if you are not good at communicating, it's going to be a very difficult job for you. And I always find when I have medical students who might be interested in histopathology or trainees and I bring them on a tour of the lab, everyone's surprised at how much work goes into the tissue sample becoming a slide.
That's huge.
And I blame House for this because multiple times when I watched House, I'm probably showing my age, House is probably donkeys years old, but it was always like, they always did a brain biopsy and it's always just like, take the brain biopsy, put a smear on a piece of glass and underneath the microscope and, I see this. I'm like, that's not what happens.
That's not how this happens.
That's not how this happens. So there's, this tissue involves, it goes through multiple chemical processes before it can be turned into that piece of glass slide. And also when you think about it, if you have something like in my case, a mastectomy, how they're turning a 3D specimen into multiple 2D images onto slides. And then in your report, you're converting it back into a 3D specimen in words for the clinician to interpret.
Yes.
So basically you really need to be good at communicating. But yeah, so the scientists, multiple scientists to each consultant pathologist to deal with all those steps and also to keep on top of all the quality assurance and quality procedures that are necessary.
Well, that's the other side, isn't it? I mean, outside of your technical work, the work that you're trained to do, in a lot of instances, docs and their scientific team are dealing with accreditation, and particularly we're talking about ISO 15189 when we talk about here in Ireland or the UK and in Europe. And that's not necessarily something that you get trained on when you're in college or university.
Oh, no.
But it becomes such a fundamental part and such a time-consuming part of your day-to-day process for both the scientific staff and to an extent the doctors that oversee a lot of that. Talk to me a little bit about that.
Well, I think if a normal person went in and saw how much work went into quality assurance and accreditation. So I suppose for someone who wants to know what I'm talking about, say accreditation. So we have a body in Ireland, the Irish National Accreditation Board, or we call it INAB for short. And they offer this service of externally auditing and inspecting laboratories to make sure that the laboratories comply with recognised international standards. As you mentioned, the regulations, the ISO
15189 particularly.
ISO 15189. And this process is so involved and so detailed that a lot of labs, you'd have one scientist dedicated simply to overseeing all of that.
Sometimes more, actually.
And sometimes more, exactly. And it's incredibly involved. And I mean, look, it's not fun, but it's necessary because ideally you have that external audit to show that, yes, you are meeting the correct quality standards, that you're providing a service to the standard in order for that patient to have a diagnosis. And something I suppose I always puzzled about a little bit in Ireland is actually a voluntary process. A lab can volunteer or not volunteer to undergo this process, except in the case of blood transfusion makes complete sense, obviously.
Yeah, of course.
I suppose in my mind, I don't really understand. I mean, I think probably it shouldn't be voluntary, but that's the way it is. But it's incredibly involved process, but it's giving assurance to your patients or your customers, I suppose, your service users.
The end user, the service
users,
to know that there's a standard there that's been adhered to, which is important. But it does take, I mean, from conversations with people in the lab and having worked with labs myself for the last 20 odd years, it's a very involved process. It takes a lot of time and dedication. Some labs on occasions miss it, and some labs have to hand it back, and then labs regain it again, depending on. But it is a difficult process, but a necessary one, as you mentioned. I know it's something now that you yourself have worked hard on in your own specialities within Limerick to develop that. You have your
We
breast
have-
service ISO accredited.
Yes, we have accreditation for breast and lung in Limerick. Yeah.
Which is excellent. That's fantastic. And then I suppose just to kind of look to the future a little bit. Where's it all going, Máire? What will histopathology look like in 2030 and 2040 in Ireland?
Okay, well, obviously I don't know for certain. I don't have a crystal ball, but what I'm seeing my own role evolving in that in the past, I'm going to seize breast because that's the area I work in. But in the past, 20 years ago, you got a diagnosis of breast cancer and everyone got the same treatment. They all had a mastectomy. They all got the same chemo. It was kind of, you have a cancer and just nuclear...
One size fits
one
all.
size fits all. And we're completely moving and have moved away from that to personalised, tailored care. And it's not just the histopathology now. There's all the extra tests and different biomarkers. So in breast, I'm sure people are probably already familiar, like, does your breast cancer respond to estrogen? And if it does, then you might get an anti-estrogen chemotherapy. And all these, I suppose, extra tests are happening, and some of them are molecular, some of them are involved genetics. And I see more and more our roles as pathologists, not only the diagnosis of the tissue on the slide, but also compiling all this information and overseeing it all, and advising then our clinical colleagues along those lines. And even the diagnosis is changing. So what another area that's now being explored and on the mainland is being used for in some lung cancer diagnosis is circulating tumour DNA.
Okay.
So detecting tumour cells in blood tests. And as you can imagine, lung is a very difficult place to stick a needle into. And sometimes you try to get a biopsy and you just can't get it without obviously severely harming your patient. And in the UK and in Europe, they're taking that blood test, circulating tumour DNA blood test, as if that's positive, that would be, that with your radiology could be enough evidence to treat, even though you don't have that tissue diagnosis. Okay. So again, that's evolving as well. So I do see I think there will always be a role for that. I'm going to say that slide, even though it's on a screen for that tissue diagnosis. But there are so many extra tests that the pathology reports forever lengthening and becoming more and more personalised, and treatment is personalised. And that's when we go into our multidisciplinary meetings. That's the whole point. Each patient has their own personalised treatment plan, depending on the biology of their disease. And I'm going to see that continue I think that's going to continue to evolve. And as research shows us more. And I think as well, AI, in my opinion, and someone who works with AI in research, at the moment, I don't see artificial intelligence as being the all-singing, all-dancing entity that it's being sold to us, such as, I think particularly things like when you're booking your holiday and they promise you AI can handle it from beginning to end. And maybe it can. But in medicine, what I think AI would be particularly useful for, and areas I'd be interested in, is, can a machine detect detail that a human can't? And can that detail then be used in prognosis and treatment? Will we be able to find details that we haven't been able to see before because we're limited to the human eyeball? Yeah. So things like that, I think it might be interesting to explore. Okay. So yeah, I think everything will just be more personalised and constantly tailored.
I think that's fair. And one of the, maybe just to finish on this point with, one of the areas that we touched upon was the growth of service requirements within laboratories. And of course, we ourselves run a laboratory outsourced service here. And just with that in mind, how do you think collaboration between, say, public hospitals and private labs, similar to HTS, and researchers can strengthen diagnosis and diagnostic care into the future? And what are your thoughts on that kind of partnership element of public and private entities coming together to try and strengthen diagnostics?
Mm-hmm. Well, I suppose I have a lot of thoughts on this, and I'm going to say, with respect, I suppose in an absolute ideal world, private anything would not be required, because someone would go to one centre and everything could be done there and it's all in-house and they were looked after. But in reality, it seems to be that the demand is constantly outstripping the supply of staff and supply of resources. And we, have to use private partners to their full capacity so patients can get diagnosed and treated. One thing I felt, because for a little while I did work exclusively in the private sector, and I missed, and something I think the private sector might, I suppose, develop or improve on is the lack of being able to collaborate with, I'm going to say, universities and public centres. And I think that's something that needs to be developed more, because I think we're going to be using private entities more and more to supplement the huge demand. And that doctors working in the private sector are also involved in other areas other than just diagnosis. And I think really that the private sector has a lot to offer from that point of view, because private sector is run very differently to the public sector and oftentimes more efficiently. And I think they can offer things that maybe the public sector can't offer. Sometimes to get some equipment in the public sector, you're jumping through hoops, or you're having a fun run, and the private sector might be able to provide that more efficiently.
Of course.
So I think there's more collaboration needed there. I think at the moment, I think there is a little bit of a separation, and I think it would be great in terms of achieving projects outside of just diagnosis. I think that's something to work towards.
Yes, no, I agree with you, and I think on that note, we'll bring it to a close. I've taken up enough of your valuable time today, but I want to thank you very much for that, Máire.
No, thank you for having me.
A big thank you again to Dr. Máire Lavelle for joining us and sharing her insights. It's been a real pleasure to have this conversation. If you enjoyed the episode, be sure to follow or subscribe wherever you get your podcasts, and stay tuned for more discussions with the people shaping the future of lab medicine in Ireland.